All right, well, thank you everyone so much for being here this morning. We really appreciate you taking your time out of your schedule to be with us. My name is Dr. Christine Peete. I'm the board president of the Eating Disorders Coalition for Research, Policy, and Actions. And today you are going to be hearing from a slate of experts with lived experience who will discuss the bias and stigma that Black women and girls face, leading them to struggle in silence as a result of underdiagnosis, barriers to treatment, and discrimination. Firstly, though, we're really pleased to be able to partner with Congresswomen Watson Coleman, Robin Kelly, and Yvette Clark with the Congressional Caucus on Black Women and Girls to bring you this important and needed conversation. So before hearing from our panelists, we're going to have the Congresswoman give some opening remarks. So Congresswoman Bobby Watson Coleman has served the U.S. Representative for New Jersey's 12th Congressional District since 2015 and is the first Black woman to represent New Jersey in Congress. She is a member of the Appropriations Subcommittee on Labor, Health, and Human Services and Education, and serves as the chair of the Policing, Constitution, and Equality Task Force in the Congressional Progressive Caucus. Watson Coleman has introduced legislation to ensure the safety, civil rights, and quality of life for all of her districts, especially women, economically disadvantaged populations, and other vulnerable groups.
Thank you all for being here, and thank you for this opportunity to collaborate with EDC, as well as to represent both the Congressional Caucus on Black Women and Girls and the CDC Task Force on Health, Nutrition, and Well-being. I think this fits all the categories. Thank you all for being here. It's good to see you. And I am so grateful to have this opportunity to talk with you, or to listen to you, or to share with you what I think is a very important issue, which is often overlooked. And it is good that we're discussing this on National Nutrition Month, because we need to highlight these issues more in Congress and around the country. Over 28 million Americans and 780,000 New Jerseyans will suffer from an eating disorder at some point in time during their lives. Nationwide, someone dies from an eating disorder every 2 minutes. We know women are twice as likely to have an eating disorder, while people of color are half as likely to be diagnosed. Eating disorders impact everybody, but they have a particular effect on Black women and girls. Because of broader socioeconomic dynamics such as racism and poverty, Black women and girls are more likely to grow up food insecure and less likely to have access to adequate treatment. So we must do more intentionally and accurately to diagnose, affordably treat, and appropriately respond to eating disorders throughout the country, and to do so with intersectional approach in mind. That's why I was proud to co-sponsor the Medical Nutrition Therapy Act, which was introduced by my fellow co-chair on the Caucus of Black Women and Girls, Representative Robin Kelly, who just entered the room. This bill would improve access to qualified clinicians who treat eating disorders, helping to narrow the gap in coverage. Myself, it's hard to say myself first, Rep. Kelly and our third co-chair, Rep. Yvette Clark, we really are vibing on the importance of the Congressional Caucus of Black Women and Girls and the discussion of issues that we need to elevate that have been marginalized or otherwise unaddressed. Well, together we released a report last summer, our Black Women Best Report, laying out legislative proposals to address the issues facing Black women and girls in America and the solutions that will elevate the quality of life for all if we look at what's happening to those who represent the lowest rung. This report discusses the need to address food insecurity and national disparities throughout the country. The prevalence of eating disorders and the lack of adequate treatment are connected phenomena, and we must all work together to address these problems. So I want to thank you all for coming here today. Thank you so many of you for taking a seat at the table, so to speak, as we discuss this important issue. And I certainly look forward to working with you as we navigate issues that are so vitally important to us as Black women, to therefore our families, and to everyone across the country. And it's my pleasure to be able to work with my sister in labor, Representative Watson Coleman.
And next we'll have additional remarks from Congresswoman Watson Coleman, who has dedicated her career to public service as an advocate for Illinois families. Since being elected to serve as 2nd Congressional District in 2013, she has worked to expand economic opportunity, community wellness, and public safety across the state, championing numerous initiatives to generate job growth, reduce health disparities, and end gun violence. Congresswoman Kelly is a member of the House Energy and Commerce Committee and serves on the Health Communications and Technology and Innovation, Data, and Commerce subcommittees. Please welcome the Congresswoman.
Hey everybody, I just ran for Congress. They're voting like crazy, but that's your working. So thank you so much today. Thank you for that introduction. It's an honor to be with you. Always an honor to be with my sister, Watson Coleman. I want to first thank the Eating Disorders Coalition for co-hosting this event. And of course, thank you all for being here today. I am proud to represent a district that is urban, suburban, and rural. I know that from the smallest towns to the biggest cities, our health doesn't have geographic or demographic boundaries. Proper nutrition is the foundation of health. Oftentimes, our diets contribute to the development of many chronic conditions, including obesity, cardiovascular disease, diabetes, and some cancers. Communities of color have historically faced disparities in diagnosis and treatment of chronic disease due to systemic inequalities that have manifested in reduced access to health care, healthy food, and safe places to be active. To address some of these inequalities, I have introduced, as my colleague said, the Medical Nutrition Therapy Act. This bill would expand Medicare coverage of medical nutrition therapy services for diabetes, hypertension, HIV/AIDS, and eating disorders, just to name a few. Additionally, I'm working on legislation to expand food as medicine programs to ensure that people have access to nutritious food. I'm excited for the discussion today about eating disorders in Black communities. Unfortunately, in the world of eating disorder, Black people are often misunderstood, unheard, or left out altogether. Even when patients come to the doctor with identical symptoms, Black patients are less likely to be diagnosed and referred for treatment. The same symptoms a white woman would receive in eating diagnosis in 44% of cases, while a Black woman with identical symptoms would receive a diagnosis in only 11% of the cases, or 11% of the time. We know that bias and systemic racism are the root cause of these injustices, but we can make progress. We can include Black women in the narrative from the very beginning. We need to ensure that Black women are included in clinical trials for diagnosis and treatment guidelines. That's why I'm also working so hard to pass my NIH Clinical Trial Diversity Act. I am confident that the focus on health equity and accessibility will significantly improve outcomes for Black women suffering from eating disorders. Because we know that accessible care is what really makes a difference for our health. And just, I don't know if any of you saw Oprah's special, and there was something else I participated in that talked about we're finally realizing that obesity is a disease, and hopefully we're moving away from the shame and blame. But your valuable work helps my colleagues and me craft and advance policies rooted in up-to-date scientific and medical understanding, and I'm looking forward to continuing to work with you. And I hate to run out, but I gotta go back and vote. I see my colleague saying she's busy votes now.
All right, finally, we will have some remarks from Congresswoman Diane Clark, who feels honored to represent the community that they serve. Congresswoman Diane Clark serves as a senior member of the House Energy and Commerce Committee, which focuses on all issues and policies powering American economy, including our global competitive edge in energy, technology, and healthcare, as well as on the Committee of Homeland Security, established in 2005 to address rising threats of terrorism. Congresswoman Clark is a proud, passionate member of Delta Sigma Theta Sorority Incorporated, and is responsible for public service and the values and beliefs that she and her sorors hold dear.
Please welcome them. Thank you very much, Madam Moderator, and greetings to everyone. As has been stated, I am Congresswoman Yvette Clark, and I proudly represent New York's 9th Congressional District, which is in Central and South Brooklyn. And I'm thrilled to be here with you all today. But before I begin, let me thank my colleagues and her leadership, Congresswoman Watson Coleman of New Jersey, and of course, Congresswoman Robin Kelly of Illinois. These sisters are bad, as I'm sure you observed. And I'd like to also thank today's panelists. Whitney Trotter, founder of the Bluff City Health, Amy and Bert, assistant professor of psychology studies at the University of Connecticut, Akira Gilbert, CEO of Project HEAL, Christine Pete, board president, Eating Disorders Coalition, and director of the National Center for Excellence on Eating Disorders at the University of North Carolina, Chapel Hill. Thank you all for being here for this very important, critical discussion. You know, so it's critical for all of us to realize that eating disorders affect people of all backgrounds and body types. And it's time that we raise awareness and encourage a better understanding of how to improve access to care and to treatment. While eating disorders have long been considered a predominantly white woman problem, recent findings show that eating disorders are becoming a major health issue for Black women and girls. And girls, let's be clear about that. In fact, binge eating occurs at higher rates in Black populations than in white ones. We also must acknowledge a host of issues connected to eating disorders that we often don't talk about, particularly with health professionals, friends, and family. We must realize the role of depression, while Black women can be especially susceptible to. We must acknowledge the signs and symptoms, and it's imperative for Black women to learn how to recognize both the symptoms and causes of eating disorders so they do not suffer alone or in silence. And even though Black women have higher rates of binge eating, obesity, and depression, they are less likely to seek assistance. Today's discussion, like what we're having today, I believe will help lead the way to a brighter future for all Black women and girls across the nation. Let me thank you all for being here today. I love to look out at this multicultural crowd here, and especially the young people, because you can make a difference. You can change the trajectory for our communities with your knowledge, your expertise, and your influence, because I know you're all influencers. How many likes? You can make that difference. So let me thank you once again for being here. Let me thank our expert panelists today for sharing your expertise. And let's go out and make a difference together. Thank you.
I now have the privilege of introducing our panelists for today, and then I promise I'll stop talking for a little while. First off, we have Dr. Amy Eckert, who is an assistant professor at the Department of Psychological Sciences at the University of Connecticut. She's a clinical psychologist by training with a research focus on eating disorders in children and adolescents from underrepresented backgrounds. Dr. Eckert is currently funded by an NIH Career Development Award focused on understanding the links between racism and binge eating behaviors in Black teens. She's the author or co-author of over 30 publications focused on eating disorders and mental health in youth.
Good morning.
Morning.
Just getting up, here we go. All right. Well, I am thrilled to be here with you today to talk about a topic that I'm very passionate about and that I have been doing research on and working with young people on for quite So first, I'm just going to give a little bit of an overview of the eating disorders. Chances are you are familiar with the first two, maybe a little bit less familiar with the third, and you might not have heard before at all. So the first is anorexia nervosa. This is characterized by a fear of eating and becoming overweight, as well as extreme weight control measures resulting in blood weight. The second is bulimia nervosa. So this is characterized by frequently consuming large amounts of food and feeling like you have the inability to control this behavior, and then using other behaviors to compensate for this eating, such as purging, making themselves throw up, using laxatives, excessive exercise, and fasting. So these are the two that I think most people think about when they think of eating disorders. But I also want to talk a little bit about binge eating disorder, because as was stated by one of the congresswomen, binge eating disorder happens very frequently in Black women. And binge eating disorder is characterized by frequently consuming large amounts of food and feeling like you don't have control over that behavior. But unlike in bulimia nervosa, there's no purging behavior after that. And then finally, I want to talk about other specified eating and eating disorder. And the reason I want to talk about that, sometimes we call it OSFED, is that this is other eating disorder behavior that results in distress and impairment, but there isn't necessarily the same constellation of symptoms as we see in the other three. But OSFED is actually the most common eating disorder, and it's associated with quite significant distress. So before I talk a little bit about eating disorders in Black populations, I want you to just take a second to think about what you think of when you think of the face of eating disorder. So kind of get an idea in your head, what's the stereotype that you think about. Okay. So we like to use an acronym that's called SWAG. So I'm gonna go through the letters with you and talk about that. So the first is S, and that stands for skinny. So the stereotypical person with an eating disorder probably eats very little and is very thin. They're also probably white, at least according to who is usually featured in the media. They're likely middle to upper class. And then finally, this person is likely to be female, assigned at birth, and identify as female. So it is very true that people with all of these characteristics certainly experience eating disorders. But what we also know is that eating disorders come in all shapes and sizes, and they affect people from all shapes and sizes as well. So although anorexia nervosa is one of the deadliest mental disorders, most people with eating disorders are not thin. Eating disorders also exist in people from all races and ethnicities, from all levels of income, and to people from all sexual and gender identities. So for the purposes of the presentation today, I'm really going to be talking about the race and the affluence question, and talking about how what our stereotypes look like aren't necessarily true. So turning to eating disorders in Black populations, we know that Black Americans are affected by eating disorders at similar rates as their peers, but they are less likely to be screened for eating disorders, they're less likely to be diagnosed with eating disorders, and they are less likely to be referred for treatment. So what this means is that Black Americans are suffering, but they are not able to get the support that they need. Turning to youth, which is a demographic that I work with mostly, Black teenagers are twice as likely as white teenagers to engage in binge eating and purging. And then finally, talking a little bit about food insecurity. So we know that food insecurity really spiked during COVID-19, leaving many Black Americans without enough food. And this has also been linked to disordered eating. So I'm going to talk a little bit about food insecurity. So before I orient you to this graph, I just want to mention that this has to do with food insufficiency. And if you think of food insecurity as the umbrella, food insufficiency is kind of the worst part of food insecurity. So sometimes or often do not have enough to eat. So as you can see, the blue line here represents Black households. And at its peak in July 2022, 30% of Black households were dealing with food insufficiency. At the most recent point on this graph, 22.8% of Black households were still dealing with food insufficiency. And if you look at the gray line at the bottom, you'll see that white households never went over the 10%. These numbers are even higher if we look at the less severe umbrella term of food insecurity. Food insecurity is also associated with higher levels of disordered eating, including binge eating, purging, and associated diagnoses. It's associated with developing future binge eating in adolescents, and possible reasons for this are for those receiving SNAP benefits, for example, they get those at the beginning of the month, and then as the month goes on, try to limit food intake, and then when more come in, binge eating occurs. It also could be using food as a coping mechanism for poverty, for racism, for discrimination. And then finally, for those who actually do get into eating disorder treatment, food insecurity is often ignored and it's not talked about as a factor. So my takeaways: number one, Black Americans are struggling with eating disorders. Number two, we need more funding for research to explore better treatment. And number three, food insecurity, which disproportionately affects Black Americans, and eating disorders go hand in hand. So with that, I will leave it to Dr. Trotter.
Thank you for the quick introduction of Dr. Trotter and also our final panelist, we don't play as much for this welcome here with the seating arrangement. Dr. Whitney Trotter is a healthcare professional dedicated to trauma and inclusive well-being. As a registered dietitian and psychiatric nurse practitioner, she seamlessly blends expertise in nutrition, mental health, eating disorders, and trauma to foster a comprehensive approach to client care. Dr. Trotter has over a decade of experience working as a registered dietitian, seeing various communities, such as the HIV/AIDS community, victims of human trafficking, and in the eating disorder field. Whitney also previously worked at a level 1 pediatric trauma center as a pediatric emergency room nurse. Whitney is also the owner and founder of Love City Health, a private practice specializing in bridging the gap in the eating disorder field of equitable care and social justice. Dr. Trotter co-created the first ever BIPOC eating disorders conference and has been featured in a variety of media publications. After we hear from Dr. Trotter, Akira Gilbert will do a presentation, and she is the CEO of Project Heal, the leading nonprofit in the U.S. focused on equitable access to eating disorder care. In 2023 alone, they provided access to over $5 million worth of free services, including treatment placement, clinical assessments, cash assistance, insurance navigation, and meal support. Previously, Akira served as the founder and CEO of Body Reborn, an intersectional community care organization for Black, Indigenous, and people of color who struggled with disordered eating. Her career is rooted in helping marginalized communities access critical resources, from women and girls who have experienced violence to incarcerated individuals. Akira's social impact expertise has equipped her to design, lead, and scale strategic initiatives worldwide.
That would just be my luck to. I'm so excited to be here with you all today, and my lovely co-creator of the BIPOC ED conference is here as well. It's particularly amazing because Black registered dietitians in the United States were actually less than 3%. So you have 2 Black RDs here, which is amazing in and of itself, but we have a long way to go in terms of increasing diversity within our field, and I definitely think the Nutrition Cares Act will help with that. So I'm going to talk briefly about what our role as a registered dietitian is in combating food insecurity. So we play a crucial role in helping those who are food insecure by providing education, resources, and support to improve access to nutritious food and promote health. And we do this in a variety of ways. So nutrition education. And so a lot of our role as a dietitian is we can, and I'll talk a little bit about this, but in terms of education, we do a lot of how to make nutrient-dense meals, especially for our food insufficient and our food insecure households. Talking about nutritious foods, meal planning, cooking skills, and strategies for maintaining food resources. Food assistance programs. RDs are pivotal and crucial as a part of the medical team to help families and individuals find and apply for food assistance programs. And particularly who I want to highlight is SNAP and WIC. We know that there are a lot of moms in the perinatal, prenatal, and postpartum that are at risk to be food insufficient and food insecure. So a registered dietitian is able to step in and help moms, families, individuals, parents figure out a way to provide nutritious food, support optimum health, nutritious meal planning for children. And I also want to highlight that WIC is so vital to our community because it actually can help children up to the age of 5. Meal planning and budgeting. So developing personalized meal plans that will meet individual nutritional needs and budget constraints. This can involve identifying low-cost nutrient-dense foods, planning meals that stretch food resources, and finding creative ways to incorporate affordable ingredients into healthy recipes. Community partnerships, again, collaboration with community organizations, food banks, healthcare providers, and other stakeholders to develop and implement initiatives that address food insecurity and promote nutrition education and access to healthy food. So what is medical nutrition therapy? Medical nutrition therapy is a comprehensive approach to treating medical conditions and their associated symptoms using personalized nutrition interventions. Medical nutrition therapy is something that is provided by a registered dietitian. And it's typically prescribed as a part of a broader treatment plan and may be used to manage various health conditions, including but not limited to diabetes, heart disease, obesity, gastrointestinal disorders, renal disease, cancer, and eating disorders. So kind of some of our key components of medical nutrition therapy, which is provided by an RD, include assessment, diagnosis, treatment planning, implementation, monitoring, evaluation, education, and of course, counseling. Medical nutrition therapy is covered by Medicare for diagnoses of diabetes, non-dialysis kidney disease, and 36 months post-kidney transplant. However, and if you don't get anything from my PowerPoint today, I want you to get this simple, that it's not covered for eating disorders. And MNT is an essential component of eating disorder treatment. I firmly believe that you cannot have true comprehensive eating disorder treatment without a registered dietitian on your team. As we've heard today, eating disorders are complex mental health conditions and they require a collaborative approach. The American Dietetic Association asserts that nutrition intervention, including nutritional counseling by a registered dietitian, is an essential component of a team treatment of patients with anorexia nervosa, bulimia, binge eating, and other eating disorders during the assessment and treatment across the continuum of care. So the Nutrition Care Act. The Nutrition Care Act would require that Medicare Part B to cover medical nutrition therapy services for individuals struggling with eating disorders. So again, remember, right now it's only covered for diabetes and renal disease. And so we really want this bill to be pushed through so that we can get comprehensive care for those struggling with eating disorders. The Nutrition Care Act would positively impact care for Black families in several ways. Increase access to nutrition services, address health disparities. The Black community experiences disproportionately high rates of chronic disease such as diabetes, hypertension, and obesity. Access to nutritional counseling and education can help address these health disparities by providing individuals with the knowledge and support needed to manage chronic conditions and further prevent complications. Roughly about 10%, which is about 5.8 million people, of Medicare beneficiaries are Black. Expansion of Medicare Nutrition Care Act can significantly impact care for Black families and individuals. It will empower individuals and families, and ultimately it will reduce healthcare costs. Investing in preventative nutrition services can reduce healthcare costs associated with managing disease and preventable conditions. Thank you so much. I'll turn it over.
Last thing we need. At this entire presentation about access to caring, that's what all about will be access to care today. Thank you all so much. It is lovely to be here today, as my co-panelists shared. So my name is Kara Gilbert. I'm the CEO of Project Heal. We are the leading national nonprofit organization focused on ethical access to eating disorder care, including medical and mental health. And so today, they invited me here to speak about my lived experience and all the work we've done at Project Heal and our organization Body Reborn. So I want to share two stories. One is my own, and the other is of Justin. And so long before I was CEO, I was 5 years old and I had very, very big eyes. I don't know if my eyes still feel the same size, but I spent a significant portion of my time trying to comport myself to my surroundings and make sure that I took up as little space as humanly possible. And I was controlled, and I was resilient, and I was hyper aware of the impact that I had on other people in the space that I took up. So that was me at 5 years old, and my eyes were kind of big, but I think it was a great time. And then 2 years after this picture was taken, I would experience the trauma that sparked my first eating disorder. And I was 7 years old, and no one believed me. I don't know how many of you have young children in your life and whether or not you believe 7-year-olds, but at that time, folks in my life weren't. And I say that because for years my hair fell out and my nails broke and I was in pain nearly every day. And I wish somebody had told me that it was never about the food and it wasn't about vanity, but it was around finding a path to mental survival for me with the resources and with the means that I had at that time. And we already know that nearly 30 million people in this country will experience an eating disorder in their lifetime. But we also know that that number is a little bigger. And we know that stigma and money prevented me from getting the care that I needed. And so the stigma came first, so if y'all can't tell, and either by my appearance or by because anyone's now say, I am Black. I am a Black woman. And Black people weren't supposed to get eating disorders. And so my mother grew up in Mobile, Alabama, and my father immigrated from Jamaica to the Bronx. And they were both incredibly resilient and hardworking, and they both grew up very, very poor. And what that meant was two things. Number one, they had very little tolerance for what they called nonsense. And they had very little tolerance for a child who would. And though my mother had an eating disorder for the vast majority of her life, it also went undiagnosed and untreated. Again, no one was able to see it. And so once we finally surpassed the stigma and we realized that there was a problem that needed to be addressed, there were no providers within 100 miles who treated eating disorders and had availability and took our insurance. And it still baffles me to this day, even though I do this work, how it was that my parents operated in a 2-income household, which we were fortunate enough to have, and held 2 full-time jobs each, and had good insurance, and still couldn't afford the care that their child needed. And so instead of clinical help, I took pain relievers and learned to downplay headaches that lasted for days, and a body that kept growing. And so if you did not know before today, I am here to share it now that eating disorders are both very expensive and they are deadly. And so the US spends about $64.7 billion every year on eating disorders. And so within that figure, we see around $48.6 billion lost in productivity, $6.7 billion in informal care, 4.8 billion loss from efficiency, and $4.6 billion burning in our healthcare system. So that's $65 billion a year that we spend on treating an issue, I would argue, too. And we know that eating disorders become entangled with comorbidities, as my co-panelists shared. And so throughout my career, I've observed that we often address the symptoms such as heart issues and depression, anxiety, hormonal shifts, without tackling one of the core causes of the eating disorders. And the longer we wait to intervene, the more dire the consequences. And so with that said, I started this off by saying that I also shared about a friend of mine, Jessica. And that truth really hit home about, again, how expensive eating disorders were and how they be up to way to treat them because many folks cannot access care. And so Jessica was a Black woman in a larger body who became a friend. And she had lived with an undiagnosed and untreated eating disorder for over 10 years at the point that I met her. And though some of her deepest challenges went unseen, she was told that she had a food addiction and even though she kept asking for help and she tried every avenue available to her, again, her peers were shunned and admonished, and it was also her constant restriction that actually drove her into binges. And Jessica died from health complications caused by her eating 2 years ago, and she's 40 years old. And ultimately, I believe that we failed her. She needed specialists and she needed care, and she received that admission. And so we also know that my story, just the story, aren't unique. If 80 to 90% of folks with eating disorders can never or will never access treatment, something is not working, we're doing something collectively wrong. And so that's why I'm currently here at Project HEAL as CEO, and we're legally charged to provide equitable access to care for eating disorders efforts across the country. And so we do that by providing a pipeline of care, free services, including clinical assessments, so they're culturally competent, they're held virtually, and we provide free and impartial care so that if you are seeking a diagnosis, you can receive one. Insurance navigation for those who have insurance benefits and have no idea how to work through it. If you've ever tried to work through your own insurance plan, you likely know what I'm speaking about. And then we have a network of over 350 healer circle partners across the country. So these are individual providers, therapists and dietitians, as well as treatment centers that provide pro bono care, a certain number of placements per year, and we are able to receive all applications, process them, and match the person that is seeking care to the appropriate level of care for them through our treatment placement partners, and we can do it without them. We provide cash assistance. So this year, we're able to provide $75,000 in cash assistance, specifically for travel and lodging to and from treatment, because again, it doesn't stop once the placement's made. Virtual meal support, which we offer 4 times a day through our partnership with Clinicians Incubator. And this year, at the top of this year, we integrated Body Reborn, which is the organization that I formerly ran, into Project HEAL's overall programmatic portfolio, and we offer intersectional community care for people of color with disordered eating, who are looking for not just a community to support them on their journey, but a community that acknowledges their intersectionality. And so this year, in a few months, in May, we're also getting ready to launch our clinical training program. And so that is going to be a pilot program that we're doing in partnership with Black Therapists Rock, over 50,000 clinicians in order to increase and diversify the pipeline of eating disorder providers. And so ultimately at Project HEAL, we want to open doors to healing for those that the systems fail. And we need to collectively push those levers. And so I know that I'm doing my part, everybody on this panel is, and I urge you to leave here today to think about what small or large difference that you can make of what you want to do right in this presentation today. Because ultimately there are millions of those who are suffering and struggling that we haven't seen. And we have the opportunity to do so now. Thank you.
I do want to make sure that we leave some time for questions and that there's an opportunity for some discussion. As I mentioned before, I'm the board president of the Eating Disorders Coalition. That is my day job. I'm the director of the National Center of Excellence for Eating Disorders, which is based at UNC Chapel Hill, where I'm an associate professor of psychiatry. I'm not going to belabor these points too much because I think my fellow panelists have really highlighted the idea that eating disorders are a public health concern, and this is particularly true if you come from a marginalized community. Because of the fact that there aren't enough healthcare providers who are trained in eating disorders, and because the general public doesn't have the information they need about these conditions, patients end up slipping through the cracks. So that's where my organization comes in. The National Center of Excellence for Eating Disorders, or what we call NC, is entirely dedicated to increasing the capacity of healthcare providers to engage in eating disorder care. How do we educate and train the existing healthcare providers so that they have the knowledge and the skills that they need to be able to care for all patients with eating disorders? I'll slide through these really quickly, but this just gives you some insight into our numbers with respect to training. These numbers are current through last month, but this is probably from 2019, early part of 2020 through now, in terms of the number of people that we've trained, also the number of people that we have visiting our website. Everything that we have available is freely available to anyone who visits our site. We're a SAMHSA-funded initiative, so we take that responsibility really seriously to make sure that we're disseminating information as broadly as we can. We have a number of different resources, which you can see some of them are pictured here, everything from single-page downloads of information through short videos, PCP checklists. We also have a newsletter that roughly 4,000 people subscribe to, and you can see that we reach millions of people through our social media. And this is really reflective of the idea that clinicians are getting information from a number of different places, not just online websites. One particular project that we stood up, I think it was 2020, 2021, is effort for eating disorders. So part of what my colleagues here talked about today was the need to really ensure that we are screening broadly for eating disorders, not just those who fit the stereotype that we might be struggling. So our organization develops screening, brief intervention, and referral to treatment for eating disorders, which is a primary care intervention or sort of protocol for clinicians in that setting to be able to screen for these conditions, to briefly intervene during the course of a clinic visit, and then get patients referred depending on their geographic location, their insurance status, those sorts of things. We launched this in June of 2022, my slide says. And so what you can see here are some of the metrics in terms of the traffic that's come to that site, the number of folks who have been screened, and these are pretty early data, so we're excited about the robust launch. One thing I do want to highlight is that we also have several resources that are specific to marginalized communities when it comes to eating disorders, some of which are specifically focused on the community. Some of the data that you'll see on these slides are actually from some of the research that's reported here this morning, but I'm just leaving this up here as an example to state that there are a number of different ways in which our organization is trying to upskill the healthcare community to make sure that everyone with an eating disorder is detected. So with that, I do want to leave some time to ask a few questions, or to have you all ask a few questions, and then we'll have a little bit of a call to action at the end. So before diving into that, I wonder if we could open up the floor to any questions that there may be from anybody in attendance. Yes, please, in the front.
So going back to what was said about medical nutrition therapy, is it not covered by most insurance providers, or can you elaborate on that?
Yeah, so Medicare B, when you talk about MNT, I'll start with there first. It's only covered for diabetes and kidney disease. When you're talking about commercial and private insurance, it honestly kind of depends on the plan. We have been fighting really hard for registered dietitians to get coverage for eating disorders. One thing I didn't mention, and I think I should have, usually RDs that are seeing folks with an eating disorder are seeing them weekly or every other week. And so we really want to utilize insurance to help offset that cost. And when you think about the larger picture of the economic burden, eating disorders are, in my opinion, unlike any other mental illness, because you really want the comprehensive team approach. You want the primary care, you want the psychologist, therapist, the dietitian, and the psychiatric provider as well. And so we hope that everybody has an insurance plan that meets the benefits to see every one of those providers, but we know that that's simply just not true.
And I'll just piggyback briefly on that to note that in the Nutrition Care Act, what we're asking for is for Medicare to cover medical nutrition therapy commensurate with what they're already covering for diabetes and end-stage renal disease. So there's already a blueprint for it, there's already a path for it, it's just simply making sure that the disease states include eating disorders. Other questions? Yes.
Well, I just want to say thank you to the panelists for sharing all that information and the stories were very insightful. And I just had a question. So I see a lot of these programs to help get Black communities and Black women get access to these resources, but once they reach this access, how are we ensuring that the treatment plans are beneficial for both their eating habits and for their mental health? Because I know there can be some issues of either hyper-focusing on the eating habits and then ignoring mental health, or not making sure that there's a balance between that. So I'm curious to see what's going on to help balance that out.
So what I would say is that the most evidence-based treatments that we have really incorporate both of those things. And so, like Dr. Trotter was saying, we really like to have this comprehensive approach. So you are meeting with your therapist to really talk through the mental health piece, to talk through if there is trauma that might be underlying, to talk through if there's depression that might be underlying. You're also meeting with a registered dietitian to talk through actual food and what's going on with that. You're meeting with a physician. And so because of that, we try to kind of have this comprehensive treatment. And so that's, I think, what all of us would recommend for somebody who is dealing with an eating disorder, not just one of those pieces.
Yeah, absolutely. And I think it speaks to, hopefully you all will invite us back, the larger conversation we're having. is, again, unlike other mental illnesses, not every state has access to eating disorder care. And so for families, and specifically Black families, we can't even find sometimes in their geographical, when we identify and assess an eating disorder, a place to have them experience treatment. And that's a larger conversation. I won't be able to do it justice in our limited time. But again, it's like, it's one of the main reasons I cannot stress enough that the Nutrition Care Act gets passed, because dietitians are usually kind of that first point of contact for doing that initial screening and assessment. And so it's so imperative that, again, Angela and I, it's one of the reasons why we did start the BIPOC Eating Disorder Conference too, is that people will be able to find somebody that looks like them, race, ethnicity, religion, to be able to provide comprehensive care. So that's a great question.
And I'll just add one small point, in terms of pressure to providing pipeline care, that's one of the reasons why we do so, because we are not really pushing that, number one, people will be able to access all the services that they need at the same time, and number two, that they will want to. So even if they did want to take advantage of every single program or every one thing, they might not be in the space to address their needs or at that point in time. There might be something else that we need to address in Canada. And so, for example, they might be focusing on sort of with their, RT and their therapist being part, but the conversations with their therapist also largely oriented around depression or another comorbidity that's happening at the same time. And so, want to add that problem.
The last thing I'm just going to say to wrap up that particular question is that part of what my colleagues here are highlighting is that standard of care for eating disorder treatment is multidisciplinary. With a dietitian, a therapist, a physician, somebody to really oversee all of the various components that an eating disorder can affect. And it's part of why eating disorder treatment is so expensive, because there are so many disciplines that are involved. And that's part of why we all champion things like the Nutrition Care Act that would allow people to use their insurance benefits to get the care that they need. Any other questions, folks? Well, then I'm going to just do a quick lightning round for our panelists up here. And I'm wondering if you each would be able to give our audience one takeaway point that you'd like them to leave with. What's maybe the main thrust of their particular presentation? Dr. Ingrid, I'll start with you.
Sure. I think the biggest takeaway point would just be that eating disorders affect more than the people that we see in the media. And so we need to have more funding and more legislation that really supports people who don't have enough money, who don't look a certain way, who are living in larger bodies, who are experiencing eating disorders.
Absolutely, I couldn't agree with you more. And again, as being a registered dietitian, I'm going to push the Nutrition Care Act. And I think too, like we know, especially in communities of color, like we're very faith-based, very family-oriented, and we know that in people with living with eating disorders, they really need that continuity of care. They need that community-based programming as well. And they want to oftentimes work with people that also share similar identities as them as well. And so doing the Nutrition Care Act really will help, and then Christine said there already is a blueprint laid out that really will help increase access to care, which is so vital.
I'd also say that eating disorders should be a national health priority. Not only do they already intersect with all of our current national health priorities, but we also know that the numbers are drastically underreported and people are not being screened appropriately. They are being screened, however, in terms of stigma and systemic bias, we know that Black women often go unseen and unheard in that process. And so when we think about the number of people that are impacted by eating disorders, it's not this narrow slice of the population. It truly is a much larger issue.
And thank you everyone for joining us today to learn more about eating disorders in the Black community. We hope you leave with a deeper understanding of food insecurity and the impact it has on those struggling with eating disorders, the importance of medical nutrition therapy, and the need for continued funding to better support those in the Black community. We ask that you urge your boss to become a co-sponsor of the bipartisan, bicameral Nutrition Care Act to ensure that every core component of treatment for eating disorders, including medical nutrition therapy, is covered by Medicare, which I'm sure you all know is a blueprint for our healthcare system. Additionally, if you are a House staffer, we urge your boss to sign onto the off-committee fiscal 25 appropriations letter to support funding for NC. The Senate letter will be coming up. Thank you everyone for your time here today. We really appreciate you being here.